Great. I recognize some of the names on screen, but for those of you that don't know me, I'm Annette Newman. I've worked at the Burn Center, which is just my favorite place, for over 31 years now. I never actually intended to stay. I wanted to fly and have the wind in my hair and wear a onesie, but fell in love with our patient population and feel very humbled and very lucky to have worked just in this amazing place for so long. So I'm hoping to share with you today some of the insights around campfires and fireworks. And so I'm going to share my screen. And then let me know if you can see that. All right, great. So fireworks and campfire injuries, we're going to specifically talk about, but the really cool thing about burn injuries, whilst we're going to focus on these two topics, is that standard principles of trauma management really come into play for every single patient, every single time. And so we'll talk about all of those basics. And what I really tried to do was to select case studies that we see on a frequent basis. And so some of you that have actually transported burn patients with these kind of etiologies may recognize some of this. And I actually do have something to disclose. Like Jamie, I'm not getting paid anything extra, but I hate fireworks like with a passion. I hate them. And so I'm kind of a Debbie Downer, and I talk to everybody about not having fireworks. So in our own county, the firework ground line, because as you guys know, is there's a massive well and urban interface problem this year, specific to the drought conditions. And so I'm like one of those that's on the phone reporting people if they're going against the rules. I didn't have to do it this year, but I definitely did it last year. So that's my one disclosure. I do love campfires, however, and may or may not have set a few fires when I was a youth, which is maybe why I ended up in burn. And then probably my main disclosure as we think about this moving forward and how it applies to us, especially if we don't normally take care of burn patients, is that there is a problem, right? The entire Western US is currently on fire. We could see that in our skies around Utah and have done for the last several days. So we do have a big problem. And as I was pulling some data, I saw that fireworks had caused an estimated over 19,000 fires, sorry, since 2018. I just added this data just recently, actually, just like an hour before. And then obviously 90% of wildfires are caused by people. So those are huge percentages to, again, take personal responsibility for our own actions and the actions of those that we love so that we can keep everything we love not on fire. And then there's already been over 30,000 wildfires since January of this year. And so as we think about how that applies to us, with the knowledge that there's 23 huge fires burning within our coverage area, then to be safe ourselves and share with others, because there's less than 1,900 burn beds nationwide. And just to kind of put that in perspective, when the Twin Towers fell, had one of them not fallen, it is estimated that there would have been not enough burn beds for all the patients that, and so there'd have been about 2,000 burn patients. And so we don't have that many beds. We're a very scarce resource. And you know, on our unit right now, all our beds are full. We're a 15-bed unit and we have 10 off the floors. So we're already in surge capacity. So thinking through that and what it would look like if there were additional patients needed to come to the burn center is really, really important. So here's my favorite grandson when he doesn't get his own way, which is just the awesome face that we see on a regular basis. But my objectives are as follows, and that's for you guys at the end of this hour session to be able to talk through the initial evaluation essentials required for a patient that has sustained firework injury or a campfire injury, and then to be able to prioritize management for those patients. And then to be so compelled by what I talk about that if you're not already doing it, you put it into your daily practice. But I really would love to know some of yours, and I've got a pen and I've got a sticky note. And so either, you know, unmute yourself, tell me what it is that you want so you don't look like my grandson and don't get what you want after this hour, or put it in the chat and Jamie will verbalize that. So what do you want? It doesn't even actually have to be related to this topic, but quiet group. Hopefully we get this dialogue, because I've got lots of questions to ask you. So I see there's something in the chat, a better understanding of treating burns. Great, thank you, Annalisa. I appreciate you putting something in the chat, and I'll try and monitor it, and then Jamie will help me also to be able to monitor that as well. How to treat burns better in the ED. Jessica, I love that you put that, because we actually just came up with an acute care algorithm for the burn patient that's pretty generic. We actually shared it regionally, and it's in our Healthcare Coalition annex, but it goes through exactly how to care for an acute burn in the emergency department. We've also got one for EMS as well. So I would love to share that with you, and it is actually on our website, crisisstandardsofcare.utah.edu. And if you go into the burn disaster segment, then it is a part of that Healthcare Coalition annex, but I'd love to share it and send it to you. If you want to put your email in the chat, then Jamie can take that down, or take anyone's email, and I'll shoot you a copy of that. How to educate the public so that we see a reduction of burns related to these topics. Cynthia, that is awesome. I would love to get the message out there, and it's great because it's a great segue into our first topic, which is about fireworks. So I'm putting education of public and ED. Great, and then I've got P. Giles. And Jamie, will you write that down for me? Thanks. Sweet. Perfect. So I've got a couple of emails, and I'll send that algorithm to you so that you can use it or adapt it to whatever it is that you need it for. Thank you for sharing. So let's jump right into fireworks, of course, that I hate. So there are 230 people a day go to the emergency department around this time of the year. So there's this month, right, around Pioneer Day and around the 4th of July, and fireworks are sold. And so there's all these people going into the ED with these injuries, or not going into the ED, and then we'll see them several days later with some issues. So the risk obviously is higher in children ages 5 to 19, and then that adult age group 25 to 44. So these are actually fit right into the case studies that we're going to talk about. And most of those injuries involve fireworks that consumers are permitted to use. So it's not like we're pulling in all these illegal fireworks and all these people are getting injured. These are actually consumer fireworks that are sold. And the other thing that's really important that addresses education of the community is to think about this culturally, because this is a cultural problem, right? So at the bottom, I put this birthday cake, and we all, give our kids birthday cakes if we have kids when they are a year old. So they have this like big old head and this really small brain. And what happens is when they blow out this candle, they think they can control fire. And not only can they control fire, but they're rewarded for playing with it, which is crazy with gifts and cake. And that's really important for us to remember as we move forward with cultural considerations, because we don't think this through. And if you look at the middle picture right there, we've got this little kid, and little kids don't always just have one sparkler. They have a big wad of sparklers, and then they circle them, and then the tips fly off, and they go down their friend's shirt, and they set their friend's shirt alight, and now their friend's on fire, and nobody knows what to do. And do they get charged with grievous bodily harm? But these guys are minors, so how does that interplay? So these are all really important things to think about when we give our children something that's as hot as a blowtorch, and when we reinforce year after year after year on the birthday the fact that fire is fun. And so ensuring that we educate appropriately per the age group, right, is really important. And sometimes I think that we've lost the ability to educate the adults. It's too late, but we can step in and we can educate the kids. And so now that you have will have some of this knowledge. Sharing it is really important, and then we have lots of stuff on our burn center website that can be shared too. But this is culturally really sticky, right? And it's not like we can wrap anyone up in cling wrap or bubble wrap, which is exactly what I did to my child. That's not beer, by the way. It's apple juice with like ice cubes in it. But it's very sticky. So to talk to somebody about not behaving how they have behaved for generations and generations, and their grandfathers did it, and this is how many fireworks they attach together, and it's a great time, and some of their behavior centered around fireworks is very tough for some people to hear. So let's go into our first case. Again, this is pretty common that we see come through the burn center. So we've got a 10-year-old male, and he's playing with fireworks and one exploded. So the EMS go onto scene. He's transported to a local emergency department, but his GCS is 15, right? He's awake, alert, and oriented, and yelling and screaming, and his skin is starting to slough and fall off. And from that picture that you see right there, so the blue is very superficial, which means it's got probably big old blisters, and that red area is pretty deep, because fireworks, we just talked about, they can be as hot as a blowtorch, and that can cause a significant burn injury and not very much time. So this kid sustained a 6% total body surface area of injury, or TBSA, as we say in the burn world, to his flank and his buttock. And he's complaining of pain, right? Because these burns are painful. You've got all your nerve endings that are now exposed to even the passage of air. They're painful to look at, right? So that's another thing that I actually do have to disclose to you. Some of the pictures you see, you might not like them. We have permission to use all of them, but it's a very painful, and it's a lifelong injury that can cause some severe issues. And now this kid is in the ambulance. So for you guys that are EMS compadres on there, he states, my pants were on fire and my cousins were trying to put the fire out, and goes to this outside hospital, and then he's transferred to the burn center. And this is his initial injury. So firework injuries tend to be pretty small, but these are actually atypical of firework injury. Most firework injury occurs to the hands and the face. And if you think about how important those areas are, when those areas have scar formation, or if we're talking about fine motor or gross motor movement and the impact on the rest of your life, that can be a big problem if it's not treated accurately. But this kid's injuries were on his flank and then on his buttocks. But then, if they're on his buttocks, what about when we pull up pants? What about if this child plays sports, and how does that look down the line? And this child did play sports, and this was a big problem for him. So let's really quickly do a review of core concepts, because I want to set you up for success, because I want you to answer the questions as we go through a case in a couple of slides. So for those of you that have never taken care of a burn patient, whether you be a scene responder or whether you be a hospital first receiver, this is the same as every other patient. It's the standard principles of trauma management. So your ABCDEs, your airway, your breathing, your circulation, your deficits, and your exposure, and then your secondary survey. You do the same thing every single time. Now, the interesting thing is there's a couple of burn caveats, right? Because we think about how big our airway is and our patient's airway, and it's, the size of your pinky, so that can occlude really easily, and it's an area that's not really visible. And so that's what we're constantly in the back of our mind thinking about. Is this patient's airway okay? And obviously it's the first assessment piece. So in the burn world, we ask ourselves a couple of questions. Is the airway patent right now? Yes or no? Can the patient protect their airway? Yes or no? Do we have an inhalation injury? And that one's a big right? So if we think about inhalation injury, then, and we're going to talk a little bit about this in one of the other case studies, that there was an inhalation injury that had been sustained as a result of the injury, then that's a big trigger for us. But for you guys that are in the EMS world out there, it won't necessarily impact your patient right away. It will impact hospital receivers and the ICUs or wherever the patient's definitive care site is day 2. For the EMS out there, your patient should typically be oxygenating well unless their carbon monoxide levels are high. So that's a caveat. Does the patient have an inhalation injury? That's a big Do they have facial injury with edema? Because there are lots of faces that can be injured, but is there edema formation? And how will that edema formation impact that trachea, right? That's the size of your pinky. And so thinking through that. And then this is the big one, but this guy has a 6%, so how does that interplay? So is your patient, do they have a burn injury that's greater than 20%? And I say that because that's the trigger for a full body swell. So if I have a burn to my hand, all the way up to my shoulders, inclusive of my hand itself, that's 9%. So if I have a burn to my arm, that's all that's going to swell. But if I have a burn to 20% of my body, which is an entire leg and a part of my arm, then I'm going to swell everywhere, which even if my face isn't burned, it may impact my airway. So keeping that in the back of your mind is really important. Now, that's not to say that people that have greater than 20% injuries do always get intubated. I can think of a couple of patients we've had on our unit that they have been over 20% and they've not been intubated, and we've been keeping an eye on them. And that's not to say that patients that have an injury smaller than 20% are not intubated, but that's kind of that cue for you to think about. Obviously, your breathing is typical, right? Are they stridorous? Are they wheezy? Are they tight? Are they hoarse? Hoarseness is a big one for us. If they sound like a lounge singer, but they're not a lounge singer, then we get a little tight, right? We're worried about these patients. And then do they have pulses? So thinking through your regular patient flow and your assessment of your patients, what do they look like? What do they sound like? Are they hypotensive? And I put a slide in about this too as a caveat, because we're talking about firework injuries here, right? So that involves an explosive mechanism sometimes. And those patients, burn patients are not hypotensive, right? Because if you're burn, it triggers fight-flight response. So your burn patients are all tachycardic. They're all hypertensive or normotensive. They won't have a low blood pressure. That's not how it works. But if you are a responder and you're seeing a patient with a low blood pressure, that's not the burn that's the problem. That's something else. So that's a big one in our Cs as we go through our primary assessment, which basically is for you guys to figure out if the patient's going to live or die in the next few minutes. And if they're going to die, then you fix it, right? If they're hypertensive, how can you fix it? If they don't have an airway and they need one, how can you fix it? That's what the primary survey is for. And then IV access in the primary survey, right? And we're going to talk a lot about that because that leads us to talk about fluids, but we're not going to talk about it right now. And then, your disability and your exposure as a part of your primary survey. Every single burn patient should be awake, alert, and oriented. Because again, they have this massive catecholamine release. It's like they drank a 6-pack of Red Bull. And if anyone has ever done that or drank a couple of bangs or, like 2 Red Bulls even. I did 2 Red Bulls one time before I snowboarded, and I swear I was like all jittery, but that's how our patients are. They're super alert. They recognize everything that's going on. So if they're not alert, then is there a problem with carbon monoxide? Is there an associated injury? Could there be additional trauma that you should be thinking about that will kill your patient? Your burn, again, in the first couple of hours is unlikely to kill your patient. So that's really important. And then we want to expose our patient and ensure that we can visualize everything. So if any of these in the airway is something that is wrong with your patient, so maybe your patient's got a greater than 20% burn and has facial injury with edema, then even if your GCS is 15, we might think about intubating that patient. But again, it depends on, if you're EMS, where are you? Who is in your crew? Are you guys ALS? And if you're not, please know that we can manage anyone, usually up front, with just a BVM. So that would be an important thing to think about. So as we jump into our secondary survey, remember this is a prelim, this is to set you guys up for success for answering questions in our case study. So I'm not going to go through all of our secondary survey because you guys are nurses, you're EMS responders, and so your secondary survey is doing your full head to toe, looking at your patient, seeing if they have an associated injury, where is that at, identifying urgent surgical intervention if it's necessary. But the burn specific pieces of your secondary survey would be to determine the depth and the percentage of your TBSA. And I put depth in there because as a caveat, if you have redness and it's first degree, we do not count that into our total body surface area of injury. And that's one of the most important things to factor in, because people that do count it overestimate the total body surface area of injury, and the patients are given too much fluid because there's a fluid calculation associated with that. So we'll talk about that a little bit more, and I'll show you some data surrounding this. We talk about our patient history. Of note here, asking the patient what they're allergic to is really important, because if they have a sulfur allergy, which one of these patients did, then we can't put that white frosting looking cream on, sulfadiazine, silidine, as it's more frequently known as. We can't use that on a patient, so we have to use a different topical agent. And then this is where we calculate and start fluids if formal resuscitation is needed. And I say if formal resuscitation is needed, because this first patient, there's a caveat to this one. So, and then I threw in some additional considerations for first responders that us at the hospitals don't necessarily have to worry about. Is your scene safe? Is there still a fire? Are there fireworks hooked up? Is there something else going on? And you guys, that's your first rule of thumb before you go on a scene. So thinking through that is really important. And then the other thing that I want to say is following your established protocols around burn injury are really important. So again, if your established protocols don't involve some of the things that we're going to talk about, which is evidence-based, then changing those protocols would be really important, because we want to ensure that everybody stays in their lanes, right? And I put extinguished flames here because we've actually had some first responders have to put patients out, or the patients are still smoldering. So that hopefully wouldn't be something that would be seen at the hospital level. Hopefully the patient would be out, but we have seen some smoldering patients. It's been a long time, but we have seen them come through the ED here. So to ensure your patient's completely out, especially as we're talking about fire, and then to think through the most appropriate transportation method. If you're a BLS crew and this patient is over 20% and they may need to be intubated and your transport time is extended, then do you need to rendezvous with an ALS crew? And how does that look? So to kind of think through those considerations, knowing what you now know is really important. And then I want to pull in something that's important for loop closure, that's important for our mental health. And this is not only in the EMS world, but this is also in the healthcare world also. It is really important to debrief. And these patients are, again, they're awake, alert, and oriented. Their skin is falling off. Their injuries can be pretty traumatic. And so to make sure that you loop close, and I'm happy to loop close with you if you need a burn center debrief, how did you do, and do some quality indicators, et cetera, and to kind of talk through the patient. I've been to multiple stations and talked through some pretty difficult patient admits and pretty difficult patient calls. So to do a debrief if you need one, and then to circle back with me if you need feedback on your patient, or just use your peers for support. But that's really important to close that loop for all of our mental health, right? So let's continue with this case studies. Are there any questions before we talk through this? I don't see any in chat, and I don't hear any. Okay, so let's move on. So let's take a look at this right here. We've got a 10-year-old who suffered burn injury while playing with fireworks, and one exploded. We have injuries as you see them, and in that picture right there. So let's go through a primary and a secondary survey, and then I'm going to ask you questions. So you can put questions in chat, or you can verbalize them. So on this kid, He's yelling, his airway's patent, his breath sounds clear, his EKG shows normal sinus tach, which remember is normal for this patient. The only people that don't have normal sinus tach are those that are taking beta blockers, so they're unable to have that sinus tach. So the other thing too, in the back of your mind, if your patient isn't on beta blockers and they don't have sinus tach, then what is going on, right? That's like, what else are you taking? All his pulses are palpable. He's moving all of his extremities. His skin's blistering and sloughing off, and he's shivering, right? Because once you're burn injured, you lose the ability to regulate your own temperature, especially in larger burn injuries. This is a smaller burn injury, but then you've got that shock response as well. So he's got burn injuries as you see them. His vital signs initially are 110 with a blood pressure of 127/56. His respiratory rate is 24. Remember, he's 10. His O2 sats are 97, unable to get a temperature on him. His pain score is 10, because remember, this is really, really painful. GCS is 15 and his weight is 35 kilos. So you are thinking through that in your primary survey. So let me ask you a couple of questions. Is this patient in need of airway protection right now? No, Jessica, nice job. No, no, he's not. Don't intubate him, please. So he's not in need of airway protection. Nice. I've got some no's in here. Great. No, he is not in need of airway protection. His GCS is 15. He's got no burns on his face. He's not over 20%. All of those things that we talked about. So where would you place his IV, and how fast would you start the fluids? And this I put in without giving you guys information to see if anyone knew the 2012 burn fluid guidelines. But I'll give you the answer in a minute. I'm watching chat. Where would you place the IV? Right arm. Nice, Pamela. Yeah, anywhere, right? He's got lots of options. And if you can't get an IV in, then you're going to place an IO in, because even if this patient has a small burn injury, he's hurting, right? And we're going to talk a little bit about pain management also. So you may not necessarily need an IV for fluid per se, because this is a small injury, but he will need some assistance, and so will his parents, who are probably frantic because they let him play with his cousins and they knew there'd be a problem. But anyway, and you're going to start the fluids at 250. So there's set amounts, and I'm going to show you them in a minute. So could there be other problems beside the burn? Remember the etiology of injury. I mean, there could, right? So if we think about fireworks, we think about, what kind of fireworks was this, and some of the most scary out there, this is why I hate fireworks, are shell and mortar fireworks, and they're totally legal to buy, and they cause 40% of the injuries that we oftentimes see, and they can lead to amputations, they can lead to losing an eye. They're the worst possible case scenarios, right? So yes, there could be other problems. Hopefully they'll be visible. Definitely if he had an amputation, you're going to see that initially in your primary survey, right? But there could be something that you've missed, but there could be other additional problems for this kid. So let's move on to, yes, blast injury, nice. Blunt trauma, nice. Yeah, so it depends on how big his cousins were and if they jumped on him too, right? There might be some traumatic mechanism there dependent upon that, and sometimes we'll see that, and folks will land on a stick or a rock or a spike or whatever is sticking up when somebody dives on them to put them out. So let's move on to secondary survey. So here we've got our sample, right? Your patient's allergic to sulfur, which is a bummer because you can see that section right there, right on his buttock. is pretty deep. It's going to be there for a while. And we use silver sulfadiazine or silvadine as a broad spectrum antimicrobial, so it covers gram-positive and gram-negatives. The rest of the injuries, they can do with just a little bacitracin, which covers mainly gram-positive agents. So not being able to use silver sulfadiazine is kind of a bummer. We're going to have to watch this. Of course, his last meal was typical peds meal or kid meal or teen meal or whatever. Bag of chips and a soda about an hour ago. You do your head to toe, everything checks out, your pupils are equal and reactive, and then you repeat vital signs, you're still tachycardic, you're still hypertensive really for a pediatric patient, your respiratory rate's a little elevated, right? He's hurting, his sats are good, and his temperature is 36, you finally get a temp on him. So are you guys really worried? Is there anything that you're worried about? I see some shakes. No, this is like relaxed time. Your primary survey checks out, your secondary survey checks out, your patient's oxygenating, he's probably yelling. If he's not yelling, that's a problem, right? You want to, in the back of your mind, think, why isn't he being appropriate? What's going on that he's not responding appropriately to this level of pain, which is 10 of 10, 70 out of 10, very high, right? Very high. So how would you determine fluid requirements for this patient? Does any of you know the consensus formula, or Baxter or Parkland as it's sometimes referred to, but it's now the consensus? I'm gonna flip to this right here, and then we'll go back. So remember, fluid resuscitation is incredibly important. Now, this patient's only 6%. And I will say this up front, that we do not formally resuscitate typically any patient that is under 10%. That's why the ABA referral criteria mentions 10% as a referral criteria to the burn center. But given that information, I will tell you about some patients that were 6 or were less, that were very close to arrest because they didn't get enough fluids post-injury. So we factor this in, we think through this, and we're very cautious. But for the most part, patients aren't formally resuscitated, but they are watched, dependent upon how much fluid they're taking in and then putting out. We watch urine pretty closely here. So this is the consensus formula. So this came out in 2012. And what it says is, in the primary survey, that if anyone's under the age 5, you just start the IV generically at 125, because you don't have time to think about anything else other than, are they going to live or die? And then for your 6 to 13, and this kid's 10, we're going to start at 250, and then your adults, so anyone over the age of 14, we're going to start it at 500. And then we may dial down or we may dial up in the secondary survey. But the secondary survey, you've established that your patient's not going to die, but really, right? And so then it's time to estimate the total amount of fluid given. And if you go into the website, so the crisisstandardsofcare.utah.edu, we have pre-calculated rates, and I'm happy to send out books to any of you if you want to put your information in the chat, and then Jamie can get it to you. But I'm happy to send out pocket guides to folks that all of this is pre-calculated in. And so that consensus formula is 2 to 4 mils times the total body surface area of burn injury, which is a little tricky. We'll talk about that in a minute, times the patient weight in kilos. And we want to give half of that over the first 8 hours. And in order to get an hourly rate, we divide that by 8. And then this is a kid. He's under the age of 14, and he's not quite 40 kilos. So we're going to start him at 3 right there. So that's kind of what we do. And then how are you going to provide pain relief? What would you do for this kid? He's yelling, he's screaming, he's 10 out of 10 pain. He's watching his wounds. Remember, he was on fire. That's super scary. That trauma that surrounds that is incredibly important to remember. He was on fire. His cousins were trying to pat him out. He stopped, dropped, and rolled. Nice job, Cynthia. Yep, you're going to give him some narcotics. Maybe you give him some fentanyl, maybe you give him some morphine. But remember, whatever is in your protocols. And what's really important here is that you will not be able to take away all his pain. You won't. And if you do, then he's not breathing, which is also really important. And so small amounts, frequently adhering to your local protocols, remembering that there are other ways that we can take away the pain. And we're going to talk about that in a minute too. So small amounts frequently with reassessment, always IV, nothing IM, because we don't know, because of the way edema works, when that will be dispersed to the body. So now you're giving a shot and nothing's happened. Now you're giving a shot and nothing's happened. And now you're giving a shot and now your patient's not breathing. So that's really important. Everything should be given IV. RIO, right? If you're not able to get an IV, and then an IO is a fabulous option. So how are you going to address the wounds? It's like all on this side right here. He's got some stuff on his chest. How are you going to address the wounds? Or are you? Do you need to? I love that there's no answers here, because there really isn't an answer. You can do whatever you want. You don't have to dress the wounds, right? You can just leave it all open. You can put a blanket over it. You can put a dressing over it, as long as you don't put topicals. That's important. Don't put any topicals on it, because then we've just got to wash it off. And if your patient has topicals on, and usually that may consist of mayonnaise, mustard, it could have toothpaste. So if your patient has any of that stuff on them, don't try and rub it off. We'll rub it off when we see it, but that is a part of the burn urban myth and legend, and none of it's FDA approved. So that should give you a cue as to whether it works or not. But what it does is it covers the burn, right? And so therefore it stops the air from hitting those exposed nerve endings, so it feels better. And that would be key. Butter, they actually it used to be the only cold thing that folks had, right? And so that's where the butter urban myth and legend came from. They put butter on it and it was cold and it took the heat out of the tissue and it felt good, but none of that really is effective. And none of the burn coolant topicals or blankets or jellies have ever been proven to assist in wound healing. What they do is, again, they make it feel better. So that would be what you would do for dressing. And then, does the patient meet criteria for burn referral? And I guess I give you the answer to that already, because yes, he was transferred to a burn center. And even though he's not 10%, this is a pretty deep burn, and a 3rd degree burn of any size does meet referral criteria. So let's move on with this case. We already talked quite a bit about fluids, but let's talk a little bit about depth of injury, partly because I love seeing pictures of Warren. He's one of my favorite people, and he's actually working on the burn unit today, but he's got a pretty great 1st degree injury. This is not counted. Remember, we already talked about that. If your patient has 1st degree injury, if their epidermis isn't sloughing off, if you can rub your fingers over it and it blanches and it doesn't be removed, then you do not count that area. The rest of it, so your 2nd degree will oftentimes have a blister. It might be intact, or it might be kind of broken like this one. It will be red and oozy and drippy. This is your deeper 2nd, kind of in this picture below. This is gasoline caused. And then this right here is actually from a campfire injury. We're going to see this patient upcoming, very, very deep. That kind of injury will need surgical removal. And then again, all of this factors into your total body surface area of injury. I love this right here. The palmar surface of your hand, inclusive of your fingers, equals 1% of your body. So this is a 10-year-old. His hands are probably the size of mine, because this is a kid. I actually know this kid, so his hands were kind of the size of mine. So then it would be, as a first responder, I'd be 1, 2, 3, 4, 5, 6, right? But if it's a ped, or if it's a bigger adult whose hands are bigger, then again, compensate for that. This is really difficult, right? This kid's yelling. If you're a first responder, he's very loud. If you're a first receiver at the hospital level, this kid's still really loud. If you've never seen a burn before, this is pretty traumatic for you. And before the patient has been completely debrided, which includes quite a lot of narcotics, then we're not going to be able to truly estimate, but we'll be able to guesstimate the total body surface area of injury. And we use lots of exotic charts that are not used in the field. So Lowland Browder is something that we do. So we've talked a little bit about pain management. Again, no IM, IV is recommended. But remember, you have alternative techniques. So I'm going to pick on Zoe in the audience. So if you, Zoe, if you're a responder, I'm not sure whether you're a nurse or you're EMS, but I saw the breakdown in the polling. But regardless of whether that, you telling the patient who you are, so hi, I'm Zoe, I'm going to be your nurse today. I'm going to give you as much pain medication as I can, but I also want to let you know that I'm not going to be able to give enough to take it all away. I'm just going to be able to take that edge off it. The reason that you hurt is because you've got exposed nerve ending. It's really painful injury. So let's cover that. Let's be really gentle when we hold it, when we move you, when we roll you. Let's, if the burn is on the arms, putting the arms or the legs around heart level decreases that pain load, and covering it with even a dry Curlex or a blanket stops that, again, that passage of air getting to it. So those alternative techniques, those distraction techniques, asking, hey, Johnny, what is your favorite thing to do? What are your cousin's names? So distracting him while he's in the back of your rig, or while he's in the trauma bay or the ED or wherever he is that he comes to. And then remembering the trauma of the event, right? Not asking the patient to relive it over and over again would be really important. That's pretty traumatic. And letting the patient kind of, go through this, right, in a positive way, and remembering mental health, pulling them in if this patient isn't going to be referred, but making sure this patient has follow-up for exactly that would be really important. And then here's the ABA criteria. Again, this patient does make criteria, even though he wasn't 10%, he was third degree. So there also is the use of images that are really important. In fact, there's a lot of data around this. I know that it's not in the EMS field yet, but one of these days your EMS are going to run onto scene with a camcorder, right, like on their head or like on their chest. It's just going to be awesome. We're going to be able to look at it. We're going to be like, oh, this patient's going to be fine. Don't intubate them or whatever. But we're not quite there yet. But there's a lot of research going on for that. But this is a really great tool to use at a first receiving hospital where maybe there isn't a burn center and the patient may or may not need to be transferred to some kind of specialized care area. So, but the use of digital images is really important. And we have a MedPick app that can be used. It's HIPAA compliant. The patient's image gets sent. Our team looks at the images on the other end and they'll be able to give direction. It may be as easy as, no, that patient doesn't need to be transferred. Thank you for the referral. We can follow them up in our outpatient area, or we can follow them up via distance, especially because we cover 5 states, right? Utah, Idaho, Montana, Wyoming, and up in Nevada. And getting a patient to drive down from Montana for a burn that doesn't need to be seen, that can be followed via distance, doesn't make fiscal sense, especially when folks are really struggling in this current environment. So utilizing images to assist with the right place, with the right treatment at the right time is very useful. So let's take a look at this patient, right? So this is the patient who was admitted and then 2 days later was discharged. And I know that in many worlds that means the patient's done, but in our burn world, the patient is never done. And we actually follow them for a long period of time. So you can see that here are the wounds to 23 post-injury. You can see these beautiful skin buds that are starting to grow right here. And then it didn't quite have the outcome that we wanted. So this patient did end up with a skin graft to that 3rd degree area on kind of his thigh. So that was him 54 days post-injury. This is 29 days post his surgery. So you can see some pictures of fresh surgery here. And then again, you can see that donor site and the skin graft there. But now that these patients have long-term follow-up, they have scar control issues, they have psychosocial needs, and their family need support, especially if they feel guilt associated with the injury. And we often see this, especially in our pediatric patient, because our most scald injuries happen in those under the age of 5, or we think about this particular patient. How does that impact the family dynamics, and how can we help them to move forward in their burn journey as they recover and become a survivor? So here's the thing, you guys, I'm going to finish the other one with this too. Prevention is the cure, right? If something's as hot as a blowtorch, why would you give it to a small child? If something can blow your hand off, why would you also, I don't know, touch it? But again, factor in my bias around fireworks. I'm sure there are lots of you out there that are thinking, woohoo, you are not stopping me from playing with mortar devices on the 24th. But really, prevention is the cure, knowing kind of the caveats around fireworks, ensuring that children are always supervised, and that you review with them how to stop, drop, and roll, because, you know, I don't know, I stop, drop, and roll a lot because that's my job. But if you think about the last time you guys stopped, dropped, and rolled, it might have been 50 years, right? I don't know. And do you remember how to stop, drop, and roll? Because the lady in our next case didn't. And so, so there's more. So let's take a look as we come to the last 12 minutes or so. Let's take a look at campfire injuries. And I want to really thank, I know she's not on here, but Melissa Gren, and some of you might know her if you're, especially if you're affiliated with the U, but she's a fabulous photographer. And so I use a lot of her images with permission, of course, but she's taken a great one of a fire there. So the facts for campfire injuries is that they affect the very young or those with impaired judgment. So have a designated adult always around a fire. And then most of the campfire injuries are caused by embers. So here's the thing, that campfires can retain their heat for up to 12 hours. So if you have little kids and you just entered a campground, but the fire is out, you're like, oh, let's put up the tent and let's set everything up and let's get our food on the table. But your little one is probably, you know, roaming around, and then remember they're fascinated with fire because you guys started that when they were a year old. And so then they toddle to the campfire pit and then they look in and they've got those big old heads, right? Because remember, they've got big old heads and really small brains, and then they go forward with their big old head, and so they land on their hands and their face. And so most of those injuries occur from fire pits that are no longer lit, but the embers are still hot. So if you want to kind of really put those out and be safe with small children around, make sure you pour water on it, make sure you stir it up, and make sure it's completely out and it's cold, right? And then most of the children's camping injuries are campfire related. So that circle of safety around a campfire, actually it should be for adults too. If it had been for these adults in this case, then they wouldn't have been injured. But that 3-foot circle of safety around a campfire, the same as 3-foot circle of safety around a stove when you're cooking, right? And then these injuries can be avoided. But we pulled to some data over a 10-year period, and we average about 23 campfire injuries a year with a length of stay of around 12 days. And our average burn size is 10.5. So you can see these are bigger injuries than our firework injuries, which tend to be less than 10%, but outpatients number in the hundreds on this. And again, you can see that little guy, this is a typical injury, less than 1%, very small injury, but can significantly impact the long-term outcome and his ability to move his hand if the correct treatment and therapy isn't administered. So here's case 2. We've got a 43-year-old female. She fell into a campfire while camping. She ran around, right? She forgot how to stop, drop, and roll. Nobody had, you know, had her do that recently. And, you know, we learned it in kindergarten, but it's still very applicable. So she ran around. Her boyfriend jumped on her and he put her out and he called 911. There was some alcohol involved in this. And so folks can't, you know, think as clearly around that. Patient was transported by the EMS to the local ED. Again, the GCS was 15, and then she was transferred to us. So let's take a look at those initial injuries. You can see that this is very significant, right? She fell face forward into the fire and put her hands out. So this is a typical injury of a pediatric too. So this could be adult or ped. They fall in with their hands and then their face gets injured. So we're looking at, again, a significant injury. So Let's take a look at her primary survey. So she's got soot around her nose and on her tongue. She's got her eyebrows and her eyelashes singed. Remember, she ran around on fire. So she's breathing in that smoke. Breath sounds are clear, but she does sound a little hoarse. So she's a lounge singer, but she's not a lounge singer. She's in normal sinus tach, of course. Her pulses are palpable right now. She's blistering, her skin is falling off. And again, she's shivering. Vital signs are 114, 145 over 76. The respiratory rate is 20, so it's high, right? She's hurting. SAT is 94%. Her temp is 36.2. Pain score again is 10. It's very rare. The patient will report less than 10, and she's about 50 kilos. So is this patient in need of airway protection right now? Let's just say for our EMS compadres. So you're a scene responder, you rendezvous in the middle of nowhere to these folks in their campsite. Does she need intubating right now with a GCS of 15? Got some yeses in there. Yeah, I mean, she might not need it right now, because we think about what we've got, right? Are we with a crew that that can intubate? Because this might be a search and rescue team, right? And there may be only BLS. So so you can administer oxygen to this patient and she'll be fine for a while. Swelling comes progressively over time. So this might be a patient that a BLS crew may call into the closest healthcare facility, and then they say, hey, we've got a patient on the way. She's got facial injuries. She's got a pretty big burn. I estimate about 20%. She's starting to swell already. Her voice sounds hoarse. And you might need to have the intubation equipment ready for us when we roll through the door, because she's probably going to need tubed. So conveying that information would be really important. But if you have the ability, and this is a patient that you feel needs to be intubated, we would never say to anyone, why did you intubate? That's just not how we roll. So again, you are the person on scene making those decisions. She is a little hoarse. So how does that interplay? And she does have a significant facial injury. Where would you place the IV, and how fast would you start the fluids? I'm interested to see if you remember. Okay, somebody put a number in the chat, or you can yell it out. This is an adult. How fast should you run the fluids in the primary survey? 500. Nice. Jessica, I love you right now. Thank you. Yes, you start the IV anywhere. If you can't start an IV, you put an IO in, and you start it at 500 in the primary survey, right? Because that's why you worry, is the patient going to die? And you just start it at 500. You don't have to calculate anything. Could there be other problems? I mean, maybe some head trauma. Pam, I love that you said this. This patient actually was worked up for head trauma also, so there could be a TBI. She fell in the fire and alcohol was involved. So so we do want to consider some of that. And does she have appropriate vital signs for a burn patient, or does she have appropriate vital signs for a patient that is burned but has a traumatic mechanism also? So we think through that. So let's move on to secondary. She's got a mix of first, second, and third. That's typical, right? No allergies, no meds, pack-a-day smoker, drank several glasses of wine prior to this incident, and then fell into the campfire. There's some favorite stories I have, but unfortunately I don't have time for them, because I know that we're coming to time. But we hear some very interesting stories that come from these patients. Your head to toe checks out, pupils equal reactive, vital signs are still pretty stable, but her temperature goes down to 35 too. You're out in an environment, it may be cooler on a night. Despite these temperatures that we're seeing right now, it does cool off. And so remember, your patient will take on the environmental temperature. They can't maintain their body temperature, and let's look at how that translates out. So just for time, you guys all know how to estimate TBSA, rule of nines. We'll skip fluid requirements. We already talked about dressing the wounds. But let's talk about how you would keep this patient warm. What are you going to do? How are you going to warm this patient up? This is really important, by the way. This is one of the biggest killers. We've got airway, that's important. Yeah, Stephanie, you're going to use warm fluids, and thinking through that for those folks that are receivers in an ED and pre-warming the environment and getting that ready for these patients, especially if they're bigger injuries like this, would be really important. That would really help. And then obviously not keeping the patient exposed for long periods of time as they get worked up for whatever kind of traumatic mechanism they had as well would be important. So our core concept here, yes, plastic sheet. Yes, I love, Jessica, that you said that. Plastic is great and it's cheap, right? Bags over heads, but not over faces probably, especially if they're not intubated. But plastic is great. Mylar blankets are great. Then the blankets don't get wet because a wet blanket can lose more heat via evaporation. So keeping those blankets dry and restocking frequently, that's perfect. So if we think about core concepts, definitely airway swelling is progressive. This patient was intubated. So nice job to you guys that identified that need. She also has an inhalation component. And what that means is she breathed in the smoke. But EMS won't see that day one because she's still oxygenating, but then day two, she's a complete whiteout on her film because these nice spongy alveoli are now fluid filled, and the chest x-ray is terrible. And so these patients don't do very well. We identified the fluids, nice job, and that this is an adult, and know that I'm skipping through these pretty quickly because fluids really do matter. There is evidence around that they cause increased edema, they cause the need to intubate when intubation isn't necessary, they cause abdominal compartment syndrome, and they can cause lung issues, ARDS like symptoms. And so we want to be sure to give the evidence-based amount, but like Goldilocks, not too much, not too little, but there is an amount that we're working with here, and there is evidence surrounding that. And I do a lot of chart audits, and I've seen some people that have had their entire 8 hours worth of fluid given in the first couple of hours, and that has bad side effects, and sometimes those patients can end up needing ECMO. So the lung bypass, especially pediatrics, are really susceptible. So, but here's what I want to focus on in the last few minutes. Temperature affects tissue. There's 3 zones in a burn, right? The zone of hyperemia, which is the area around the malleolus, is going to heal no matter what. The area of coagulation, the zone of coagulation, which is the white area, it's dead no matter what. You can't bring it back. But there's the zone of stasis, which can be impacted by warmth and by fluid. And so those people that are responding first, so first responders and first receivers, can severely impact the long-term outcome of the burn patient, because that injury, if it doesn't get enough warmth, if it doesn't get enough fluid, or it gets too much fluid, then it can convert to a 3rd degree. So that's the zone of stasis. So we're looking at that. And then there's also something that is very well documented. And if you haven't heard about it, you absolutely have to Google it. It's called the triad of death. And obviously it's bad because it's got the word death in it. But that is absolutely a core concept, and it's usually triggered by hypothermia. The patient then gets lactic acidosis, and then they start to bleed, right? They become coagulopathic, and they won't die on you, they'll die on us, because it starts this toilet bowl effect and we can't pull them back. But they don't die on first responders or first receivers, they die down the line because we can't fix this. It's very difficult. So ensuring the patient doesn't ever get into that is very important. And I guess the pearl here is, in order to know your patient's temperature, you actually have to check it. And that's really important. Pre-warming the environment, minimizing patient exposure time, especially if they're coming through as a trauma, the use of warmers, which was already identified, no wet dressings on these patients. We've talked a little bit about trauma, and I know we're at time. Remember, the vital signs will be different for burns. And then know that in chart audits, every single time too much fluid continues to be given, and the temperature is the #1 missed vital sign. So like my favorite grandchild, I never get what I want, or it's very, very rare. And so please kind of think through that. And just as we come to close, this is that patient, right? Because you guys, as first responders and first receivers, you see the acute trauma, but you don't see the long-term. And so I wanted you to take a look at this. So this is 26 days post-injury. This is 34 days post-injury. This is 138 days post-injury. And then this is the patient on day 190. And she did not survive this injury. She's relatively young, she's relatively healthy, but sometimes patients don't do well, and this patient did not, and broke a lot of people's hearts. So to carry this message forward, And then to also ensure that you close the loop on any of the patients that you transfer to the burn center, because most of them survive. And I would love to give you a report out on any of those patients. You can even come visit if the patient approves. But to close that loop for you is really important. We've talked about some of these already, the core concepts that you guys in the field that are transporting patients, securement of the airway, adhering to evidence-based fluid, keeping the patient warm, don't getting distracted by what's not really going to kill your patient, which is actually the injury itself, at least in the first little while, and ensuring that you're careful around pain, follow ATLS, adjust based on your patient respond. If they're not responding appropriately, if they don't have tachycardia, but they're not on beta blockers, what else is coming on? Did they just come from a rave out at Saltaire and they got burned in the parking lot? What else is on board here? So kind of thinking through that. But mainly just, you guys are awesome. We really take report and take referrals from some amazing providers. So thank you to all of you in the field that do just such an amazing job. Thank you to all those first receiver folks that we've got listening on here. Thank you for all that you do. You do a fabulous job with our patients. And then again, just in closing, prevention really is the cure. Ensuring that there's a designated person around a campfire, ensuring that you talk to folks about that 3-foot circle of safety, that you're cautious is really important. And to know that there's limited burn capacity in the United States. We know our capacity in the West. The West is that big blue area right there. We're actually readying ourselves for the coordinating center for the West. And if there's any wildland fires occur in that entire region, then we would be the response for that. And so we are preparing ourselves for something terrible in the hopes that something terrible won't happen this year and that all can stay quiet on the Western Front. But thank you. For all that you do. Is there any last minute questions as we go to close?
I'm going to launch the polling questions while we're opening it up. Like I said, please feel free to come off mute, ask any questions.
Oh, thanks, Cynthia.
And Cynthia, I agree. I always have to use Annette once or twice throughout the year in some sort of presentation.
All right, Jessica, any ideas for quick temps when the patient is wet? Yeah, that's tough, huh? I would say, you know, dry them off as soon as you can. So some of these patients that I think about oftentimes, you know, initially when a burn patient gets burn injured, then we do throw cool, not cold water on them, right, to get the heat out of the tissues. But after about 15 minutes, 20 minutes, if you're Canadian, cooling that patient is, you know, you saw first responders whose average response time is about 7 minutes urban, but definitely longer for rural, then that's not what they do. They don't wet their patient or anything. But if your patient is wet, getting that water off your patient, warming your patient up, ensuring that any wet blankets are removed and warm dries are placed on, never ever using any kind of wet dressing ever. And then if you have, you know, like a jelly blanket, that can be really cooling to your patient. So to factor that in. And we usually say it's okay to use in a very small burn injury, but a burn injury over 10%, that cools the patient down very quickly. And so if you insist on using it, although we don't recommend it, especially in bigger burns, then monitor the patient's temperature really closely.
Yeah, and I know, Annette, we've seen people like first receivers use a bear hugger and put blankets over them as your burn comes in, because sometimes you just can't get that trauma bay hot enough.
Right, that's really
warm enough.
great.
I know you walk into the burn area and I am usually sweating the minute I walk in the door. I wish we could get our trauma bay that hot so we could keep our patients warm. But yeah.
It's a great environment, but I like the heat. Well, thanks everybody, and thanks Jamie for the invite. I always love to teach, so I'm always up to teach one of my passions, which is burn injury. So thank you.